Good evening, everyone. Anyway, the session has started late. We are starting the session. So, I am inviting now Spurti to present a case series of keratoconus. Spurti. Spurti. Who is the next presenter? Dr. Rishita. Nothing is mentioned here. Sure, 5 minutes. Huh?
Good afternoon, everyone. Yes.
Okay, fine. Carry on. She'll be Rishita. She'll be talking on. She is presenting a paper on correlation between keratometric and refractive astigmatism in pseudophakic eyes. Wonderful. Carry on.
Good afternoon, everyone. I am Dr. Rishita, and my study is on correlation between keratometric and refractive astigmatism in pseudophakic eyes. Financial disclosure, no conflict of interest. Cataract, the word is being derived from the word cataracta from Latin, which means waterfall, and cataractus, a Greek word which means downrushing. The goal of refractive cataract surgery is to provide an excellent uncorrected visual acuity and zero postoperative refractive astigmatism. Refractive astigmatism is predominantly determined by the total corneal astigmatism, so it is important to establish a numerical correlation between corneal and refractive astigmatisms. The aim of the study is to evaluate correlation between keratometric and refractive astigmatism in pseudophakic eyes. The study is a cross-sectional prospective study done at Dr. RSPR Government Regional Eye Hospital, Visakhapatnam during the period of June 2023 to August 2023. 120 eyes of 120 patients attending the inpatient department services of Andhra Medical College, Department of Ophthalmology for cataract surgery. All patients who underwent a small incision cataract surgery with superior limbal incision with a posterior chamber intraocular lens implant in the study institution during the given duration were included, and patients willing to participate were also included. Exclusion criteria: patients with preoperative astigmatism of more than 2 diopters, patients with corneal pathologies, patients with retinal pathologies, previous history of any intraocular surgery, abnormal iris or pupil deformation, complicated cataract surgery were excluded. Study methods: demographic data of all patients included in the study was taken. Best corrected visual acuity was assessed with Snellen's visual acuity chart. Anterior segment with slit lamp biomicroscopy. Posterior segment with plus 78 diopter lens. Keratometry with Bausch and Lomb keratometer. The observation is mean patient age taken in this study is 71.05 plus or minus 8.50 years. Mean axial length is 23.49 plus or minus 1.80 millimeter. The gender: males were assessed more, and more right eyes were assessed than left eyes. Coming to the studies parameters, the Snellen's visual acuity chart, both spherical and cylindrical power was taken, and keratometric astigmatism was assessed preoperatively and postoperatively in all the patients. The first graph shows the keratometric astigmatism, the second graph the refractive astigmatism, and the third graph internal astigmatism. The mean values are plotted, and these are the graphs attained. Coming to the J0 component, which is the horizontal component, the keratometric values, the mean value is plus 0.07 plus or minus 0.29, and the range is minus 1.35 to plus 1.23. In refractive, the mean values are minus 0.01 plus or minus 0.27, and the range is minus 1.95 to plus 0.96. The J45 component, which is the vertical component, the keratometric values, mean values is minus 0.12 plus or minus 0.36. The range is minus 2.35 to plus 0.61. In refractive astigmatism, the mean values is minus 0.10 plus or minus 0.25, and the range is minus 1.15 to plus 2.32. The p-value is less than 0.0002, which is significant. These are the regression analysis of the J0, which is horizontal component, and the vertical component J45's regression analysis graph. In this current study, we found that the refractive astigmatism in pseudophakic eyes with a good corrected distance visual acuity differed significantly from the keratometric astigmatism, and according to our data, the keratometric astigmatism explained about 30% of the subjective refractive astigmatism. These findings indicate that factors other than keratometric cylinder induce astigmatism in pseudophakic eyes. In fact, the so-called internal astigmatism, which is in a pseudophakic eye, may be caused by a tilted IOL, or the so-called retinal astigmatism may play a role in modifying corneal astigmatism. Similar findings were reported by Tews et al., Mendicutt J et al. In their study. In conclusion, keratometric astigmatism was responsible for about 30% of the refractive astigmatism in pseudophakic eyes. So the surgical technique, most importantly incision placement and size of the incision affect the post-operative keratometric astigmatism. My references are following.
A single surgeon or different surgeons usually?
Taken superior scleral incision or superior limbal incision? Oh, limbal. You sutured.
Are you APOS or AIOS? APOS? This year only. Okay, fine. I need to see ratification status. Okay, fine. See how astigmatism you mentioned. How will you differentiate between refractive and keratometric? How will you differentiate both?
The axis in keratometric, it will be along the axis, sir. For refractive, it will.
How will you differentiate keratometry from refraction? You mean subjective refraction?
In subjective refraction.
Refractive status means subjective refraction. Okay, fine. Okay, fine. You used Boschenbaum keratometry.
Boschenbaum keratometry.
Okay, madam. Fine.
Thank you.
We coming to next presentation for Hana. Knowledge, attitude and practice study of eye donation among patients attending okay, fine. Next, Mubashir. Different types of corneal foreign bodies. Yeah. Post injury and its correlation with specific occupations. Yeah. SU Medical College. Okay, good. Yeah.
Good afternoon. My name is Mohammad Mubashir, and my study is on different types of corneal foreign bodies post-injury and its correlation with specific occupation. I have no financial interest. The aim of the study was to know about the different types of corneal foreign bodies post-injury and its correlation with specific occupation. A hospital-based prospective observational study was conducted at Ophthalmology Department Tertiary Care Center from July 2022 to June 2023. 90 cases of corneal foreign bodies were included in the study who fulfilled the inclusion and exclusion criteria. Inclusion criteria: participated voluntary in this study, age between 10 years to 60 years. They are diagnosed or had a suspected diagnosis of corneal foreign body and were able to complete their anterior segment examinations. Had had lesions with a depth that did not exceed 2/3 of corneal thickness. Exclusion criteria: age less than 10 years or more than 60 years. Full thickness penetrating corneal injury with corneal foreign bodies. Injury with signs of corneal infection. Results: 90 patients, of which 12 females and 78 males with a mean age of 36.7 plus or minus 10 years were included in the study. This table shows the affected patients mostly belonging to the age group of 31 to 40 years, which account for 42%, followed by 41 to 50 years, which accounts to 23%. This was followed by adults between 21 to 30 years, which accounts to 21%. There were 78 males and 12 females. Male to female ratio was found to be 6.5:1. Corneal foreign bodies is common in right eye, which accounts for 56% compared to left eye. Table 2 shows most common corneal foreign body material was metallic iron particles, 53%, followed by dust particles, which accounts for 16%. Other particles like wood, matter, thorn, which accounts for 11%, glass 7%, insects 5%. Table 3 shows industrial workers were most commonly affected, accounting to 54%, followed by construction workers 15%, domestic work 11%, corneal foreign body trauma due to agricultural work was 10%, and other occupations account to 8%. This depicts the location of majority of corneal foreign body was paracentral 62%, followed by central 20% and peripheral 17%. This table shows that total 65% of injury of corneal foreign bodies could have been prevented by using protective eyewear. Injury has doubtful prevention with protection, and only 8% could not have been prevented with the use of protective eyewear. Discussions. Sir? At that time we took available patients and some from.
These are your pictures?
Yes, sir.
Really? You know who has written this paper?
Somewhere, did you find any similar paper?
Yes, sir.
Papers anywhere else?
Yes,
Where?
sir.
Who is the author of the paper? References you have
Dr.
given?
Yes, sir, Dr. Ajay.
No, references you have given, no.
Yes.
Go to the references. Go to the references. The whole paper you have copied, my whole paper. Copy and
He
pasted.
was the other primary
I am the primary author of
He
this
totally
paper.
copied entire
And these
paper.
pictures are my pictures. And you have not changed. Sample size, everything you have copied. You didn't expect me to be a judge here, no? You think we are fools? And this type of presentation where you cannot do a paper while you are presenting. This whole of my paper you have copy and pasted my pictures. How you have taken those pictures? With what?
From site.
Who is your, like, you are the presenting author, somebody will there, no, who is your, you are only the presenting author. Nobody is there. But you have copied the whole of my thing, copy and pasted.
You didn't change even data, even
Data
photos
you have
also.
mentioned A, B, C.
Photo.
How is that? Will I show this in my iPhone? Those are the pictures now.
He has taken from his phone.
You know, I have an innovation adapter also. I have taken from with a SitLab adapter all those pictures. And you have copy pasted nicely. Chalo.
Okay, fine. Next presenter will be Katikala, study of severity of dry computer users. Vishwavarthi Medical College, Kurnool. Not there. Next, a study of changes of meibomian gland dysfunction before and after cataract surgery. Dr. Krishna.
Good afternoon, everyone. I'm Dr. Krishna Priya, and today I'm here to present about a study of changes in meibomian gland function before and after cataract surgery. No, there are no financial interests to disclose. And coming to introduction, meibomian glands are the large sebaceous glands that are located as separate gland strands in the palar arrangement within the tarsal plates of eyelids, secreting oil layer which keeps tears from drying up too quickly. Meibomian gland dysfunction. This is the most leading cause of evaporative dry eyes, which might be due to obstruction of terminal ducts or changes in the glandular secretion of meibomian glands. And prevalence of meibomian gland dysfunction in Asia is about 46.2 to 69.3%. And my aim of the study is to study the effect of cataract surgery on meibomian gland function, and we have included both the small incision cataract surgery and phacoemulsification. And coming to objectives in the study, to observe the effect of cataract surgery on meibomian gland function and to assess if type of cataract surgery has any role in meibomian gland dysfunction. Coming to materials and methods, this is an analytical observational study which we have included 60 of sample size, and here we have divided into two groups, 30 who underwent SICS surgery and 30 who underwent phaco surgery. We have sampled with convenient sampling, and informed consent and institutional ethical clearance has been taken. Study duration was 3 months, and inclusion criteria, we have included more than 40 years of age, and patients with normal meibomian gland function, and patients with senile cataract undergoing uneventful cataract surgery. Exclusion criteria, we have excluded pre-existing infective or inflammatory ocular pathology, complicated cataract, traumatic cataract, subluxated lens. And coming to meibomian gland function, we have been assessed using teophyllum breakup time and Schimmer's test, meibography. Actually, meibographer should be used, but due to unavailability in our settings, we have used customized meibography by autorefractokeratometer and OSDA questionnaire. These are the set of questions to be answered by the patients. And coming to data analysis and statistic analysis, descriptive analysis of continuous data was performed, and meibomian gland function parameters before and cataract surgery within SICS and phaco groups respectively were compared using paid t-test, and intergroup postoperative changes in meibomian gland function was compared using independent sample t-test, and p value less than or equal to 0.05 was considered to be significant. Coming to results, there are significant change between the pre-op values and the post-op values in parameters of dry eye in Schimmer's, T-BUT, OSDI score and Meibo score. And coming to post-operative SICS and phaco post-operative values, there are no such significant difference. And coming to discussion, in our present study, we concluded that there is compromise in meibomian gland function, causing dry eye symptoms after cataract surgery, irrespective type of surgery. And coming to Gadby et al., who have included 120 patients in their study, have concluded that incidence of dry eye after cataract surgery was high and mostly independent of demographic and anthropometric profile and type of surgical procedure. Hankon et al., who have included 48 patients in their study, have concluded that meibomian gland function may be altered without accompanying structural changes after cataract surgery. Limitations: meibographer is ideal for studying and analyzing meibomian gland morphology, but due to unavailability in our settings, we have used customized meibographer, that is autorefractokeratometer, which works on same principle. And coming to conclusion, there is compromise in meibomian gland function causing dry eye symptoms after cataract surgery, irrespective type of surgery. And these are my references. Thank you.
Any questions, Raghav? Raghav? Any questions?
Thank you.
Ajay? Yeah. First, affects meibomian function.
Sir?
Why the study is done for, and I want to know in which way the cataract surgery affects meibomian gland function.
Sir, actually, they complaining of dry eye symptoms after cataract surgery, sir. So usually in these T-BUT or is it dry eye parameters, they are compromised. They are decreased due to compromise in oily layer, sir. So oily layer which is secreted by the meibomian glands, it is ought to be compromised in meibomian glands, sir.
postgraduate.
Yes, sir.
Which year?
Second year, sir.
Nice.
Thank you, sir.
You did shimmers 1 or 2 for these patients?
One, sir.
Which one is better? 1 or 2? What is 1? What is 2?
Without anesthesia is one, sir. Without anesthesia is two, sir.
Which one is better?
Without is better. Sorry. With the anesthesia, patient compliance is better, sir.
And not for the study purpose. Which one is better?
With anesthesia, sir, because basal secretions will be.
Yeah, nice. Okay, fine.
Thank you, sir.
Next, Kasi Lanka Radhika, prevalence of dry eye disease among medical students. Yeah, nice. Ashram.
Good afternoon, everyone. Myself, Dr. Radhika. Today I am going to speak about prevalence of dry eye disease among medical students in a tertiary care center. There are no financial interest. Dry eye disease is a multifactorial disease of the tears and ocular surface that result in a symptoms of discomfort, visual disturbance and tear film instability with potential damage to the ocular surface. It is accompanied by the increased osmolarity of the tear film and inflammation of the ocular surface. The overall prevalence of dry eye disease ranges from 5 to 50% depending upon the criteria, age, sex and population studied. It is usually more common in Asian populations than in Caucasian populations, and prevalence rate increases with age. Although numerous studies have been conducted to investigate the nature of dry eye disease, only few studies have been attempted regarding the characteristic of dry eye disease in healthcare professionals. Aim is to estimate the prevalence of dry eye disease among medical students in a tertiary care center. Objective is to study and analyze the dry eye parameters in medical students and to assess the association of dry eye with average screen time in medical students. My study type is cross-sectional study. Duration is of 3 months. Sample size is 100 students. Sampling method is consecutive sampling. Study population is medical students of Ashram. Study area is Department of Ophthalmology, Ashram, Eluru and Andhra Pradesh. Inclusion criteria is medical students who are willing to participate are included. Exclusion criteria is the students having glaucoma, strabismus, severe trauma, contact lens wearers, undergone refractive surgery for vision correction, other ocular eyelid surgeries that may affect the ocular surface health. Approval was obtained from the Institutional Ethics Committee. Written informed consent is taken. The study have been conducted by using questionnaire with 2 sections. Demographic data with pre-existing medical condition and average daily screen time, and a dry eye questionnaire using the ocular surface disease index. All students underwent routine ophthalmological examination along with shimmer test and tear film break time as a screening tool for detecting dry eye disease. Tear film breakup time, an impregnated fluorescent strip moistened with normal saline is instilled into lower fornix, and patient is asked to blink several times and observed under cobalt blue filter in slit lamp. Breakup time less than 10 seconds is considered abnormal, and test is repeated 3 times and average is calculated. Shimmer's test, it measures the amount of wetting of Wortmann 41 film paper. According to the wetting of the shimmer strip, dry eye was graded as normal when the reading is more than 15 mm. Mild dry eye is 11 to 15 mm, moderate dry eye is 5 to 10 mm, severe dry eye is less than 5 mm. OSDI questionnaire overall score were calculated and categorized into 3 groups. Normal score 0 to 12, mild symptoms 13 to 22, moderate symptoms 23 to 32, severe symptoms 33 to 100. The data was collected by self-administered method. Data analysis, the collected data was entered in Microsoft Excel 2010 and analyzed using SPSS 20.0 version. The results were presented in the form of tables. Descriptive statistics were used to summarize the demographic data, and Fisher's exact test used for comparison between categorable variables. The mean age of the study participants are 21.88. In a OSDI questionnaire, 52% of the study sample is normal, 17% has mild symptoms, 16% moderate and 15% have severe symptoms. Shimmer's test, 60% of the sample has normal, 29% mild and 11% moderate. T-BUT, 58% of the sample has normal and 42% has abnormal. In association with average screen time, dry eye parameters, OHDA, Shimmer's test and T-BUT has significant statistical association as p-value is less than 0.01. Discussion. In this study, there is significant statistical association in dry eye parameters with average screen time in medical students. UH3 et al. Study concluded that drastic increase in usage of digital devices after the initiation of COVID-19 lockdown, and there is increase in prevalence of dry eye disease among medical students. Lograj et al. Stated that prevalence of dry eye disease is more among medical students, and more exposure to screen time has strong association with dry eye disease, which is also similar to our study report. Conclusions: the prevalence of dry eye disease among medical students is rising as a result of increasing screen uses. Awareness about prevention of digital eye strain should be enforced in medical students to bring these adverse effects to a minimum level. These are my references. Thank you.
Before discussions like discussion में पहले वाला slide. How did you do the fixed extract test? Exact test.
By using SPS software with variables, comparing the variables.
So you had a questionnaire. What questionnaire you had?
OST,
That's it.
only one question, and average screen time I take it by in the phone. There is digital well-being app. From that we take the average screen time.
Radhika, sir. Yeah, next.
Radhika.
Karupati Vasavi. She is presenting a paper. Is there a correlation between dry eye symptoms and mybography findings by auto in individuals with diabetes?
Good afternoon everyone, I'm Dr. Vasavi. My topic for presentation is there a correlation between the dry eye symptoms and the mybography findings by autorefractometer in individuals with diabetes? Financial disclosure, no conflict of interest. Dry eye is a common disorder which causes ocular discomfort and vision issues due to abnormal tear production, evaporation or tear composition. Meibomian glands in the eyelids form the lipid component of the tear film, which helps in preventing the tear evaporation and maintaining the tear film stability. When these glands malfunction, it is called as meibomian gland dysfunction, and it often leads to dry eye. Autorefractometers, which are commonly used for checking the refractive errors, have infrared technology for visualizing the meibomian gland. This simplifies the study of gland abnormalities and their connection to the dry eye symptoms in people with diabetes due to their widespread availability. Aim of my study is to investigate the potential correlation between the dry eye symptoms and the mybography findings assessed by an autorefractometer in people with diabetes. This is a cross-sectional study. 50 patients of diabetes mellitus with dry eye symptoms who fulfill the inclusion and exclusion criteria attending the OPD services of Government Regional Eye Hospital, Visakhapatnam were included. Inclusion criteria is age more than 18 years and symptoms of dry eye. Exclusion criteria is recent ocular surgeries, ocular systemic conditions affecting the ocular surface like connective tissue disorders, recent contact lens usage, use of medications affecting the tear production or ocular health, pregnancy or breastfeeding. Study period is 3 months from June 2023 to August 2023. Data is collected from the subject who met the inclusion and exclusion criteria. Total 100 eyes of 50 patients is included in the study. The comprehensive evaluation of the study participants included the following key assessment: demographic data and clinical history, slit lamp examination for assessing the ocular symptoms, lid issues, vascular changes and meibomian gland dysfunction, focusing mainly on the MGD. Tear film assessment, we have done tear film height and T-bud for stability, and dry eye assessment is measured using ocular surface disease index questionnaire. Mybography is done using an autorefractometer, and we have used 4 grading system as proposed by Arita et al. Grade 0 is no gland loss, grade 1 is less than 1/3 of the gland dropout, grade 2 is 1/3 to 2/3 of the gland dropout, grade 3 is more than 2/3 of the gland dropout, and grade 4 is complete gland absence. This is the mybography findings. We can see right side picture I have marked. There is one gland loss and gland tortuosity is seen. This is a patient with mild dry eye. Meibum expressivity score, we have assessed each 8 glands in the central third of the lower lid. 0 to 3 grade on a 0 to 3 scale is given for each gland. 0 for clear meibum, 1 for cloudy meibum, 2 for cloudy meibum with the debris, and 3 for thick like toothpaste meibum. Statistical analysis was done using SPSS program and unpaid student t-test for comparing the means of the qualitative data. And Pearson correlation, R is used as a correlation coefficient. P-value of less than 0.05 is considered to be statistically significant. Observation and results. In this study, total 100 ISO 50 patients is analyzed. Here in the study, 20 males and 30 females are included, and mean age group is 52.02 years. This is the table. This is the graph showing type 1 and type 2 diabetes subgroup. In our study, 20% are type 1 diabetes and 80% are type 2 diabetes. This is the age distribution graph. Most of the people in our study are aged between 44 to 54 years. This is the graph showing OSDI versus age. As there is increasing age, the OSDI scores are proportionally increasing. This is the graph showing MEBOM expressivity score. Most of the people in our study are having a MEBOM expressivity score of 0.6, between 0.6 to 1.3 in a mean range. That is mild, that is clear MEBOM. MEBO score versus OSDI scoring. OSDI scores in type 1 and type 2 diabetes. Most of the people who are having type 1 diabetes are showing less OSDI scoring. And the results, there is a positive correlation between the OSDI score and the MEBO score, and also positive correlation is seen between the MEBOM expressivity and the MEBO scoring. The study aimed to find the link between the dry eye symptoms and the mebography findings. Dry eye symptoms are linked to the meibomian gland dropout, and dry eye symptoms and the OSDI scores are more in type 2 diabetes than type 1 diabetes. There is no significant sex disparity in the scores in our study. Longer duration of the diabetes having a higher test scores. Our studies results are similar to the Semra et al. Who done the mebography findings in type 1 diabetes in children with respect to MEBO scoring. Limitations of our study is it's a cross-sectional study, so it limits the causation, and sample size is smaller, so it hampers the subtle correlations. So future direction, explore the correlation between the longer duration of the diabetes and the MDD in the dry eye, evaluation and benefits of the improved glycemic control on the eye. Conclusion, it is essential to emphasize the use of autorefractometer for assessment of the meibomian glands in individuals for the ease of use and accessibility in the clinical settings. These are my references. Thank you.
Next presenter, Dr. Snigdha. A clinical study and microbiological evaluation of corneal ulcer in patients.
Good evening. Today my paper presentation is clinical study and microbiological evaluation of corneal ulcers in patients attending tertiary care hospital. I have no financial interest. Introduction. The cornea is a highly specialized part of the eye, and its transparency is a requirement for good visual acuity. Corneal infections can damage the integrity of the ocular surface, thereby disturbing the transparency of the cornea, leading scars and decreasing visual acuity. According to WHO, infectious uveitis is the leading cause of corneal blindness in developing countries. Coming to the corneal ulceration, which results in 1.5 to 2 million new cases of the corneal blindness annually, posing a major public health problem. Fungi are the most common infectological agents, which account for 30 to 40%, which is the major chunk, whereas bacteria account for 13 to 48% of all spread keratitis. This varies by geographical area. These pathogens lead to the corneal damage directly or by release of toxins and enzymes, or by activating the host immune system, and intact corneal epithelium acts as a barrier for the majority of the microorganisms, which can penetrate through a breach in the epithelium followed by ocular trauma. Various risk factors have been implicated for increased incidence of the fungal keratitis, including injudicious use of antibiotics and steroids, use of contact lenses, and post-operative infections as well. Ocular morbidity such as corneal scarring and subsequent visual loss can be significantly reduced by prompt institution of the appropriate therapy guided by the knowledge of the causative agents. Aim of the study is to study distribution of keratitis in various subgroups of population of different age, sex, occupation, socioeconomic status to determine the distribution of keratitis in various presenting clinical forms of disease, predisposing risk factors, microbial profile, visual morbidity of the disease. Study design, it is a prospective study done in the Department of Ophthalmology, GGH Kakinada for 1 year in 50 patients. Inclusion criteria, all in clinically diagnosed corneal ulcer cases who have given consent. Exclusion criteria, all the non-infectious keratitis at PUK, VKC, Gordon's ulcers, everything is associated shield ulcer, contact lens related sterile infiltrate, marginal keratitis, interstitial keratitis, heteromatous were excluded. Cases of corneal ulcer which were presenting with the excessive corneal thinning and impending perforation as well perforated corneal ulcers were excluded, as taking corneal scraping was not feasible. Coming to results, age distribution, majority of the chunk is seen in 31 to 40 years and followed by 41 to 50 years. This is the representation of the age incidence. Gender distribution, majority is 86% is seen in male, followed by 40% in female. Predisposing factors coming to the ocular trauma, 40% is seen with injury with vegetative matter, followed by 38% with spontaneous, injury with foreign body is 22%. Occupational distribution, agricultural workers, 42% of agricultural workers seen, 26% is industrial workers, followed by others. Geographical percentage, rural people may constitute a major chunk of the percentage, 78%, followed by urban, which is 22%. Predisposing factors, ocular trauma, it is a major chunk, 62%, followed by non-traumatic factors, 38%. And location of the ulcer is important as well. Central location, it is 44%, peripherally 36%, both it is 20%. Coming to the microbial profile, 52% of cases are from fungi, 32% of cases from bacteria, parasitic it is nil, culture negative is 16%. Visual acuity time of presentation, 6.6 is nil, 6.9 to 6.18 is a 16, 6.24 to 6.60 is 20, less than 6.60 is a 14, and after the treatment, final visual acuity, 6.6 it is 4 people, 6.9 to 6.18 is 18, 6.24 to 6.60 is 22, less than 6.60 is 6. These are the case of fungal corneal ulcer. This is the patient Adaparamba with the hypopion. Discussion, this clinical study was done in 50 patients with the corneal ulcer with the following observations. Out of 50 cases in this study, majority belongs to 30 to 50. Male to female ratio is 6:1. Males were more affected than females, probably due to more outdoor activity and more chances of exposure to contacts. Majority of seen in rural community, either agricultural laborers. Out of 50 cases, ocular trauma is the most common risk factor accounting for development of corneal ulcer. Among them, ocular trauma, which vegetative matter responsible for 40% cases. Central locations are more commonly seen. Majority of patients are presented with pain, redness, foreign body sensation, lacrimation, defective vision. Fungal keratitis is the more common than bacterial keratitis. Fusarium and aspergillus are the most common organisms isolated from fungal, and Staphylococcus aureus is the most common among bacterial. Visual acuity presentation, out of 50, it is 16% with visual acuity between 6.9 and 6.18, 20 with 6.24, 6.60, 14 with less than 6.60. Final visual outcome, it is more common between 6.9 and 6.18. Final visual outcome depends on the type of the lesion, virulence of the organism causing, and the host response to treatment. Conclusion, superiority keratitis is an avoidable vision-threatening disease that still represents the considerable proportion of daily new cases that creates huge burden on the resources of the health services. The clinical presentation of the bacterial and fungal corneal ulcers are often overlapping. Thus, confirmation by microbiological diagnosis is very essential in order to limit the ocular morbidity and prevent complications. Thank you.
So, in non-trauma cases, you done in all cases you did syringing or no?
See, only who have complained with the watering, we have done syringing, sir.
No, in all microbial keratitis, we have to do syringing, right?
Okay, sir.
So that is one of the cause.
Okay, sir.
Right?
What other things you need to check? Patients come with fungal keratitis or other than syringing, what all?
First, we have to ask for the history, sir, like matter injury or a fall of foreign body, anything.
What all investigation you sent? For all the patients. You don't send.
We will do in the.
Good.
Yeah, fine. Next will be Lavanya.
Good evening. My name is Dr. Lavanya. My topic is a study on assessment of computer vision syndrome and dry eye disease. Introduction. Computer is one of the most common office tools used in nowadays. Prolonged usage of computer led to greater risk of computer vision syndrome associated with dry eye. This is a group of eye and vision related problems that result from prolonged use of computer, tablet and cell phones. This is the most common eye problem characterized by symptoms such as dry eyes, itching, foreign body sensation, watering, blurring of vision and headaches. Aim of study: to know the magnitude and determinants of dry eye syndrome among the health professionals and to study the correlation of computer vision syndrome with dry eye disease. Inclusion criteria: undergraduate students, junior doctors, senior residents, lab data entry operators and argutory data entry operators. Exclusion criteria: persons with pre-existing dry eyes, pre-existing ocular pathologies other than refractive errors and with uncorrected refractive errors. Methods: in total 100 participants took part in the study, aged 20 to 40 years with minimum exposure of 2 years to screen time for about 4 hours every day were included. Included health professionals of 40 males and 60 females. Includes MBBS students, junior doctors, senior residents, lab data entry operators. A validated structure electronic questionnaire was developed to analyze the data from individuals. The survey included questions regarding the digital device used during the day and night time with various factors related to eye strain, dry eyes, itching and blurring of vision and watering. In total of 100 participants took part in the study, which included history followed by baseline ocular examination included visual acuity using Snellen's chart, anterior segment examination using a slit lamp, shimmer test for the dry eye evaluation, tear film breakup time, and posterior segment with slit lamp biomicroscopy using 90D lens. Questionnaire: hours spent in digital screen per day, total hours spent including the usage of computer, mobiles, and tablets: 1 to 3 hours, 4 to 6 hours, 7 to 8 hours, and 9 to 12 hours. Questionnaire: do you have any of the symptoms below? Please mention yes or no. Tearing, watering, itching, stinging of eyes, aching of eyes, redness, blurring of vision, sensitivity to light, and eye fatigue. How do you rate your eye health status before and after the usage of digital platforms? My eye health did not change. Mild deterioration in the eye health, moderate deterioration and severe deterioration in eye health. Results and observations: 100 responded to the questionnaire. Hours spent in online screen time. For 1 to 3 hours, about 11 number of subjects, 9.69% of patients complained, and 4 to 6 hours, 39 people responded, and 7 to 8 hours, 32 subjects. In 9 to 12 hours, 18 subjects were responded. Results: it was observed that 72.6% are having eye strain, 65.3% with dry eyes, and 52% with headache, 49.3% with watering, and 49.3% with redness. The most common symptoms associated with computer vision syndrome are dry eyes, headaches, blurring of vision, pain, itching and burning, neck and shoulder pain. The symptoms may cause due to poor lighting, glare on the digital screen, improper viewing distances, poor seating posture, uncorrected visual problems, a combination of all of the above factors. Solutions to digital screen related vision problems are varied. Eyeglasses or contact lens prescribed for general use may not be adequate for computer work. Lenses prescribed to meet the unique visual demands of computer viewing may be needed. Special lenses designs, lens powers or lens tints or coating may be helpful. Conclusion: this was a cross-sectional study on 100 subjects to assess exposure to digital screens and dry eye disease. Limitation of this study was assessment of computer vision syndrome and dry eye based on self-reported symptoms and with the ophthalmic examination. Majority of individuals suffer from the symptoms of computer vision syndrome. Optimizing the exposure time, improving the awareness on safety measures in preventing computer vision syndrome plays a vital role. There is need to provoke awareness among the population concerning their health effects allied to prolonged usage of computers and mobiles and tablets. Intermittent exposure to digital screens with considerable refreshing breaks in between can be helpful. Those are my references. Thank you.
How did you calculate your sample size here, 100 patients?
By using a questionnaire, sir.
By questionnaire you
100 number of.
how you calculate? How valid will be your study? That I wanted to know. Suppose tomorrow you want to publish, be a valid study. That's the question. Getting your sample size of 100 patients.
By
Do you read or not? You're which year now? I have statistics.
Thank you.
There will be Ramya Charumalla. She is not there. First presenter Spurti also. You are here. Yeah, you can present, madam. Case series of keratoconus. First one. Spurti first.
Good afternoon. I am Spurti D, Junior Resident, GMC Guntur, presenting a case series of the keratoconus. In case 1, a 18-year-old female patient came to the ophthalmology OPD with chief complaints of blurring of vision for distance since 12 years associated with frequent change of glasses, history of night blindness since 6 years, and younger sister has the similar complaints. Right eye vision was CF 3 meters, pinhole 612 partial, and BCVA was minus 4.5 spherical diopters with minus 3.50 cylinder at 10 degrees. It was vision was improved to 6.9 partial, near vision was N6, and in the left eye vision was CF 3 meters with pinhole 612 partial, and BCVA was minus 3.75 spherical diopters and minus 3 cylinder at 10 degrees. Vision was 6.9 partial, N6 was near vision was N6, and on slit lamp examination, right eye cornea has the prominent corneal nerves, and left eye cornea has prominent corneal nerves with the Fleischer's ring, and rest of all anterior segment findings were normal. And on examination, Munson sign was seen. On cobalt blue filter, left eye has the Fleischer's ring, and both eyes shows the prominent corneal nerves. And on the fundus examination, both eye media was clear, optic disc was waxy pale disc with the distinct margins, and cup disc ratio was 0.3:1, and blood vessels arteriolar attenuation veins were normal, and macula foveal reflex is present, and background retina bony spicules were present, predominantly seen in the peripheral retina. And these are the fundus pictures of right eye and the left eye. And on Bosch-Lomb keratometer, keratometric findings were right eye K1 was 45.25 diopters, K2 was 48.25, and left eye K1 was 45.25 diopters and K2 was 48.25. And these are the corneal topography images of the right eye and left eye of the patient. And case 2, a 17-year-old male came to the ophthalmology OPD with the chief complaints of diminution of vision in 3 years, which was progressive in nature. History of frequent change of glasses and history of clear vision with eye squeezing were present. No history of vigorous eye rubbing, and no history of previous contact lens wear, and no history of similar complaints in the family members. And on examination, right eye vision was 636 and with pinhole 618, and the BCVA was minus 4 spherical diopters, minus 3 cylinder at 10 degrees, vision was 618, and left eye vision was 636 with pinhole 618, and BCVA was minus 4.5 spherical diopters and with minus 3.5 cylinder at 12 degrees, vision was 618, and anterior segment and fundus examination were within normal limits. And this is the Munson sign, and right eye K1 was 45.40 diopters, K2 was 53.05, left eye was 45.55 diopters and K2 was 50.55 diopters. And these are the corneal topography images of right eye and left eye of the patient. And the case 3, a 25-year-old female surgery PG came to ophthalmology OPD with chief complaints of diminution of vision since 1 year, and there was a history of difficulty in visualizing the suture material end during the surgical procedures, and no history of frequent change of glasses, and no history of vigorous eye rubbing, and no history of previous contact lens wear, and similar complaints in the family members. And on examination, right eye vision was 624 with pinhole 612, and BCVA was -1 spherical diopters with -2 cylinder at 10 degrees. Vision was 69, near vision was 6, and left eye vision was 612 with pinhole 612 partial, -0.50 spherical dioptric spherical, and -1 cylindrical at 180 degrees. Vision was 69. Anterior segment and fundus examination were within normal limits. Right eye K1 was 44.50, K2 was 46.50. Left eye K1 was 44.20, K2 was 46.70. In the discussion, keratoconus is a bilateral and asymmetric non-inflammatory ectatic disease resulting in progressive thinning and steepening of the cornea, leading to the irregular astigmatism and decreased visual acuity, causing a conical shape of the cornea. It is an idiopathic condition. Prevalence is 1 in 700. Higher prevalence is seen in the families with the affected individuals. Associated with atopy and downs, polymorphism of lysyl oxidase gene and COL5A1 has been found responsible in many cases. Levels of degradative lysosomal enzymes like acid esterases have also been found to be increased, and dysregulated corneal extracellular matrix remodeling, particularly in the stroma. And though an non-inflammatory disease, recent studies have shown a significant role of proteolytic enzymes, cytokines and free radicals, suggesting a quasi-inflammatory disease. And on histopathology, epithelium has central epithelium thinning, Bowman's layer breaks filled with the eruptions of underlying stromal collagen, and stroma has compassion and loss of arrangement of fibrils in the anterior stroma. Descemet's membrane can tear, leading to acute eye drops in the advanced cases. And the goals of the treatment are to be provide functional visual acuity. Spectacles and soft toric contact lenses is prescribed in the mild cases. Rigid gas permeable contact lenses to neutralize irregular corneal astigmatism, and in progressive keratoconus, corneal collagen cross-linking using riboflavin and UV light followed on a 3 to 6 months basis. Intrastromal corneal ring segments in mild to moderate keratoconus in corneal thickness of more than 450 microns. And deep anterior lamellar keratoplasty involves the replacement of central anterior cornea, leaving the patient cornea intact, and penetrating keratoplasty has a high success rate and is a standard surgical treatment. Following corneal surgical procedure, patients need to be followed to complete visual rehabilitation. In conclusion, in the early stages, patients with keratoconus can achieve adequate visual correction with the spectacles, and the primary treatment mode initially was the usage of rigid contact lenses and spectacles, while for advanced cases, keratoplasty was preferred choice of treatment. And the recent advances in the treatment has introduced the uses of excimer laser application, phakic IOLs and ICRS, as well as the utilization of combination of techniques, have resulted in a major contribution to offer effective management at different stages of its progression. And these are my references.
Where you got those topography maps done?
From LVP Shankara.
These, you know, which topography is that?
Why do you get fissure ring in? So what? That's the reason, because I see lot of pigmentosa. So how you are correlating? That's the reason we have 3 cases now. So the first case, what you had RP. So that may be a very good case. The single case report you can write on that thing.
Shankara? Ramya Chirumamilla. Dr. Sona Babu. A cross-sectional study on viral keratitis, right?
Good evening all. I am presenting my study based on cross-sectional study on viral keratitis in GGH Anandapur. Viral keratitis is one of the leading causes of corneal scarring and which will cause subsequent visual disability. It will affect both pediatric and adult population, especially immunocompromised people. Both DNA and RNA viruses will cause keratitis. The most common cause is type 1 herpes simplex, that is DNA virus. The other organisms are varicella zoster virus, cytomegalovirus, Epstein-Barr virus and adenovirus. My aim of the study was to identify most common type of viral keratitis encountered in our OPD and to study various clinical presentation of viral keratitis. The objective was to determine the various clinical presentations of viral keratitis and to identify the most commonly encountered viral keratitis in our OPD. The type of study was cross-sectional observation study and the sample size was 50. It was conducted in a period of time 6 months from January 2023 to June 2023 and the place of study was Government General Hospital Anandapur. Inclusion criteria includes all the patients who gave the consent for the research and all the patients with clinically diagnosed viral keratitis attending the OPD. Exclusion criteria includes patients who are not consenting for the study, recurrent cases of viral keratitis with the superadded bacterial, fungal and other infection and associated uveitis. These patients I have taken the thorough history based on the eye symptoms, their duration of symptoms, progression and associated fever, upper respiratory tract infection. Further, ocular examination was done based on the visual acuity, slit lamp examination, fluorescein staining and cornea sensation. Treatment was given like topical antiviral, oral antiviral and topical steroids for the period of 2 weeks. These are the pictures showing the patterns, dendritic pattern, pseudodendritic pattern, subepithelial keratitis and stromal keratitis. From my study, I got the result as out of 50 patients of clinically diagnosed viral keratitis, 50% of the patients were of herpes simplex viral keratitis and 30% patients were of herpes zoster ophthalmic keratitis and 20% of the patients had adenoviral keratitis. The clinical pattern I got is 70% of the patient had epithelial keratitis, 20% of the patient had subepithelial keratitis and 6% of the patient had stromal keratitis and 4% of the patient had neurotropic keratitis. From our study we found herpes simplex viral keratitis as the most common type as epithelial keratitis as the most common clinical pattern compared to other studies such as Pramod et al. They got epithelial keratitis as 65% and Priyanka Sadhoni et al. They got herpes simplex viral keratitis as 50% and epithelial keratitis as the most common type. In reference studies, they have observed more stromal keratitis without ulceration and endotheliitis cases, but in our study we didn't observe such cases as the sample size was only 50 and the duration was only 6 months. That was the limitation of my study. Conclusion, herpes simplex keratitis is the most common viral keratitis and epithelial keratitis in the form of dendritic ulcer is the most common clinical manifestation encountered in our study. Improved understanding of the burden of viral keratitis and clinical pattern can lead up to early identification and treatment. Early diagnosis and timely intervention can reduce complications like corneal scarring and subsequent visual disability. And these are the references. Thank you.
In any of the HSV keratitis, you did scraping, like in stromal necrotizing keratitis, anything. No.
Nikhila Sai.
Good afternoon, one and all. Today I am going to present a paper on analysis of keratometric readings and astigmatism in patients with different grades of pterygium attending tertiary eye care hospital. Financial disclosure, no conflict of interest. Introduction, pterygium is a triangular fibrovascular subepithelial encroachment of degenerated bulbar conjunctival tissues over the limbus on the cornea. It is a worldwide disease which is particularly common in tropical and subtropical regions. Excessive exposure to light and dust, especially for those doing outdoor jobs, are considered as the main risk factors for development of pterygium. Astigmatism is a state of refraction in which the light rays coming from infinity will be focused onto a line due to difference in refractive power of the eye in different meridians. It is therefore graded according to its progression and involvement of the cornea. Growth of a pterygium over the cornea causes deformation and changes of the curvature of cornea, leading to differences in the refractive power of the cornea in different meridians. By encroaching on the cornea from the nasal side, a pterygium flattens the horizontal meridian of the cornea and consequently causes induced with the rule astigmatism by mechanical traction. Aim of my study is to evaluate analysis of keratometric readings and astigmatism in patients with different grades of pterygium. My study design, this is a cross-sectional descriptive study. It is conducted in Department of Ophthalmology, Andhra Medical College, Government Regional Eye Hospital, Visakhapatnam. My study period is from April 2023 to July 2023. My study population is patients with pterygium attending IOPD. My sample size is 64 patients, that is 124 eyes. Informed consent is obtained from all subjects after the nature and possible consequences of the study are explained to them. My inclusion criteria is patients willing to participate, patients with primary, unilateral or bilateral pterygium, patients above 20 years. Exclusion criteria, refractive errors before they develop pterygium, keratitis, keratoconus, recurrent pterygium and pseudopterygium. Coming to methodology, demographic data of all patients included in the study is taken. The study includes a total of 64 patients, that is 124 eyes, where 60 patients presented with bilateral pterygium and 4 patients had unilateral pterygium. Uncorrected visual acuity and best corrected visual acuity was performed using Snellen's visual acuity chart, and assessment of pterygium is done with slit lamp biomicroscopy to establish type, grade and size of pterygium. Autorefractometry was evaluated to determine the type, magnitude and astigmatism for both eyes. Refraction was assessed objectively by using a retinoscope followed by subjective refraction to obtain the best corrected visual acuity. Keratometry was done using a Bausch and Lomb keratometer. Coming to statistical analysis, Microsoft Excel was used in creating database and producing graphs, while data analysis is done using SPSS 20 and expressed in the form of charts, tables, histograms and pie charts. Coming to observation and results, 60 patients were presenting with bilateral pterygium, while 4 were having unilateral pterygium. Out of 64 patients with pterygium, half of the patients, that is 48.4%, were between the ages of 41 to 50 years. The mean age of the patient was 45.14 plus minus 9.93 years. It is noticeable that large proportion of the patients were belonging to female gender. This is my graph depicting that majority of the patients were in the age group of 41 to 50 years, and the male preponderance is more here. Keratometric readings was measured in 2 meridians, K1 and K2. The mean of keratometric readings, which were K1 and K2, were 43.05 diopters and 44.16 diopters respectively. The data indicates that most of the eyes were presenting with high K2. The findings revealed that among the affected eyes of the recruited population, a total of 41 were presenting with small grade pterygium, that is grade 2, followed by 27.4%, 22.6% and 17% are associated with grade 1, grade 3 and grade 4 pterygium respectively. The overall mean computed for the magnitude of astigmatism for all eyes was 1.429 diopter cylindrical plus minus 0.6225 standard deviations. The analysis found evidence that with an increasing magnitude of pterygium, there was an increasing trend seen with the grades of pterygium, that is grade 4 pterygium has an increased mean of astigmatism which is 0.54 plus minus 0.96 diopter cylindrical as compared with the mean magnitude of astigmatism, that is 0.11 plus minus 0.23 diopter cylindrical associated with grade 1. This is the chart depicting the same, where grade 3 and grade 4 pterygium presented with more mean magnitude of astigmatism, and this one is the overall magnitude of astigmatism, which is 1.429 diopter cylindrical plus minus 0.6225 standard deviations. This table here reports the independent association between grades of pterygium and corneal astigmatism of more than 1 diopter. P-values showed that grade 3 and grade 4 show more strong and significant association, which is 0.0001 and 0.001 respectively, if compared with grade 1 and grade 3 that shows no positive association with astigmatism of more than 1 diopter. Among different grades of pterygium, 90.4% eyes belonging to grade 4 were presenting with astigmatism of more than 1 diopter as seen in the table. Similarly, 71.4% eyes belonging to grade 3 were presenting with astigmatism of more than 1 diopter. This table here highlights the correlation between the grades of pterygium and induced astigmatism and keratometric readings as independent variables. Induced pterygium and keratometric readings show a positive relationship with the grades of pterygium, that is Pearson correlation, which is R is equal to 0.786, where P value is equal to 0.001, and where keratometric readings are Pearson correlation coefficient R is equal to 0.922, where P value is 0.001 respectively. Discussion: pterygium is a disease spread across the world and prevalence is more common in countries located near the equator. The present study was conducted to determine the prevalence of patients with pterygium coming to eye clinic, keratometric readings and type of astigmatism in various grades of pterygium. A total of 124 eyes affected with pterygium were included in the study. The prevalence of pterygium reported in the current study was 7.06%. If we compare our findings of the mean age group of patients, in which patients are more affected with pterygium, they are in line with the findings of the previous studies. Some of the reasons reported here are due to exposure to UV rays, dust and instability of the tear film playing an important role in development of pterygium, which is very common in the age group of above 40 years due to physiological changes in corneal epithelium. In this study, 27.4% eyes lie in grade 1, which opposes the findings of the study conducted in northwest Ethiopia, in which the proportion is higher, that is 64% than reported in our study. The Ethiopian study uses the surgical classification of pterygium, where there are only 3 grades compared to 4 in the current study. Also, my study depicts eyes with grade 4 pterygium had the highest mean magnitude of astigmatism. Likewise, in this grade, there was highest proportion of eyes with astigmatism of more than 1 diopter. This is in contrast to the study in Iraq, where comparatively higher proportions of significant astigmatism was found in 5 of the eyes with pterygium grade 2. In this study, most eyes presented with high keratometric readings indicating with the rule astigmatism. My study computed the correlation between grades of pterygium, astigmatism and keratometric readings, which indicated a positive correlation between grade of pterygium and amount of astigmatism. The increasing size of pterygium results in increasing curvature and irregularity of the cornea, leading to astigmatism. Conclusion: the present study concludes that magnitude of astigmatism increases with increasing grade of pterygium. Grades of pterygium established a significant correlation between keratometric readings and induced astigmatism. So my recommendations are keratometry and refraction should be done in all patients with pterygium. Those patients found to have with the rule astigmatism of more than 1 diopter need to be counseled for pterygium excision. These are my references. Thank you.
Okay. Dr. Hemasai.
Good afternoon, everyone. Myself, Dr. Hema, first year postgraduate, presenting a prospective study of dry eye after manual small incision cataract surgery. Financial disclosure, no conflict of interest. Introduction: cataract is an opacity in the lens or its capsule, whether congenital, developmental or acquired, which causes visual impairment, for which manual small incision cataract surgery is most routinely performed. After this surgery, many patients have reported of dry eye and postoperative pain symptoms. In addition, the use of topical eye drops, reduced corneal sensitivity, surgical inflammation due to the large incision created in the eye, and exposure to the light from microscope during the surgery are considered to be responsible for postoperative dysfunction of the tear film. This study analyzes changes in the tear film and production of tears after the cataract surgery. Aim is to establish the incidence of dry eye in patients after the small incision cataract surgery. Materials and methods: this is a cross-sectional prospective study done in the Department of Ophthalmology, Andhra Medical College, Government Regional Eye Hospital, Visakhapatnam, from July to September 2023, including 100 patients with cataract attending ophthalmic inpatient services. The informed consent obtained from all the subjects after the nature and possible consequences of the study is explained to them. Inclusion criteria: patients who are willing to participate from the age group 55 to 80 years and with senile cataract with or without dry eye symptoms. Exclusion criteria: cataract other than senile cataract, patients with other ocular and systemic comorbidities, history of contact lens use, patients with constant use of ocular medication, patients who have had previous ocular surgeries. Methodology: demographic details of all the patients were collected. 100 patients who met inclusion criteria were enlisted for cataract surgery. Every patient was asked about the symptoms related to dry eye, and then they underwent Schimmer's test 1 and tear film breakup time test. After this, patients were subjected to the surgery with a 6 to 7 mm superior straight incision, and then on 1st, 7th and 30th day after the surgery, Schimmer's test 1 and tear film breakup time test was again performed. The dryness of the eyes was then analyzed and graded in accordance with the 2007 dry eye workshop classification. Statistical analysis, Microsoft Excel was done in creating the database and producing graphs, while the data analysis done using SPSS20 software and expressed in the form of tables and histograms. A p-value less than 0.05 was considered statistically significant. Results, out of 100 samples, 26% had dry eye preoperatively, which increased to 89% postoperatively on first day. Out of these 89 patients, 35 were male and 54 were female. This is a line graph showing Schimmer's test. Preoperatively, 16.78 millimeters was seen. After first day after the surgery, it decreased to 7.03. Then after post-op 1 week, 7.15 mm, and 1 month, 10.45 mm. This is a bar graph showing Schimmer's test value. In our study, more than 10 mm is considered normal, 8 to 10 mm mild, 5 to 7 mm moderate, and less than 5 mm considered severe. Preoperatively, out of 100, 74 were mild, 16 were normal, 16 were mild, 8 were moderate, and 2 were severe. On post-op day 1, 26 were severe and 35 were moderate. On post-op 1 month, it is seen again, it is returning to the normal levels. This is the line graph showing mean tear breakup time. Preoperatively, it was 17.89 seconds. Then on post-operative day 1, it decreased to 7.24 seconds. After 1 week, it is 7.84 seconds. After 1 month, it is again increased to 13.23 seconds. Discussion. In this study, we assessed the dryness of eyes after the small incision cataract surgery. Reasons might be damage to the corneal and conjunctival epithelium due to the chronic use of eye drops containing preservative like benzalkonium chloride after the cataract surgery. Ocular surface irregularity following the surgery leads to the faster breakage of the tear film. Decreased mucin production from conjunctiva destabilizes the tear film. Decreased corneal sensation due to the damage to the long ciliary nerve and results in decreased tear secretions. This is the comparison of my study with other studies. Venugopal K et al. Study done in 2012 has sample size of 71, which reported peak incidence on first week, and post-op dryness at first week is seen with nearly 43 patients, and follow-up done on 1/7 and 45 days. Mean age is 62 years. Only in this study, among the 4 studies, only male preponderance is seen. In all other 4 studies, female preponderance is seen. In my study, sample size is 100, preoperative dryness assessed is 26 patients. It reported peak incidence on first day, similar to the Dodia K et al. Study, and post-operative dryness at the first week is 89, and follow-up done on 1/7 and 30 days. Mean age was 66.15 years. We observed that this improvement in dry eye syndrome could have been because of the use of a combination of antibiotic and dexamethasone, carboxymethyl cellulose in patients post-operatively. Limitation is shorter follow-up time may affect incidence in our study. A longer follow-up might have added more insight into the behavior of post-operative dry eyes. Major limitation of this study is comparison between site and size of incision with the degree of dryness was not done. Conclusion, moderate to severe dryness of eyes was seen after small incision cataract surgery with corneoscleral tunnel, which stabilizes after 1 month. We recommend the use of preservative-free lubricants, antibiotic and steroid combination. These are my references. Thank you.
I just have to ask you one question. Why you did on day 1 post-op?
So generally many
Is it easy to do like sermons on day 1 post-op?
No, sir.
And other thing is like your studies for 2 months, correct? You have done
3 months.
3 months you have done. No, that's the thing. You could have done on month 1, month 2, or month 3, what I believe, because that will have a better result. Like after, because your healing process you want to know, no? Whether it is associated with the cataract surgery that you want to know. So you can expand the study. Your limitation I understood, but it's not logic to do on day 1. Patient will not be cooperative. The incisions will be there, healing will be there, and the patient will have irritation, other thing also. Best, I can understand with phaco, you can do it, but your SIS, yes, the incision, conjunctival, you will be having all those things and all. So you can modify your study, what I mean to say. That's it. Chalo.
Dr. Manjot Kaur.
Good evening, one and all. My topic is pediatric limbal dermoid. A limbal dermoid is a congenital benign tumor which consists of a normal tissue in an abnormal location, also known as choriostoma. It presents as a dome-shaped lesion with a keratinized surface. It can invade the visual axis or infiltrate the cornea with the fat component. It gradually induces corneal astigmatism and finally results in anisometropic amblyopia in pediatric patients. The visual scoring system is used to grade the limbal dermoid. A total score of 0 to 3 is categorized as grade 1, and total score of 4 to 6 as grade 2, and anything more than 6 as grade 3. The parameters involved in the scoring system are area of corneal involvement, the surface shape, and area of conjunctival involvement. The management is surgical. Shave excision alone or can be combined with any of the following modalities like lamellar keratoplasty, penetrating keratoplasty with relaxing incisions, amniotic membrane graft, mono or multilayered, with or without sutures or with fibrin glue, corneoscleral patch graft, limbal stem cell transplantation, MMC that prevents the post-op pseudopterygium formation. The combination of these surgical interventions yields better results and a stable long-term cosmetics and fewer complications. Along with the surgery, management of amblyopia with occlusion treatment, chemical penalization with or without spectacles is also considered at younger age. This is the case report of a 6-year-old patient who reported with chief complaints of diminution of vision and foreign body sensation. On examination, the vision was 4/60, that was improving to 624. At the limbus, single pigmented solid elevated nodule 4 into 4 mm was noted at infratemporal site. Posterior segment examination was normal. After shave excision, the reconstruction was performed with a multilayered amniotic membrane graft, which was secured with the sutures. So the preoperative AK revealed the cylinder of -3 at 5 degree of axis, and postoperative AK was -2.75 at 10 degree axis. Another such case report of similar chief complaints. The anterior segment examination revealed a single pigmented solid elevated nodule having hair follicles and sebaceous glands 5 into 5 mm in size and infratemporal at site. Posterior segment examination normal. After shave excision, the reconstruction was performed with corneoscleral patch graft secured with the sutures. The preoperative AK revealed a cylinder of -5 at 150 degree axis, and postoperative revealed -3.75 at 150 degree axis. The inference, the case 2, which was reconstructed with a corneoscleral patch graft, had the following advantages. It helped restore the structural integrity earlier. It had better cosmetic acceptance. The intraoperative fewer risks of complications such as overriding was seen. And postoperative astigmatism correction or prevention of amblyopia, however, cannot be promised. Thank you.